Hello everyone. Today we are going to talk about human immunodeficiency virus infection. AIDS is a disease caused by the retrovirus belonging to the lentivirus family. It is characterized by profound immune suppression that leads to opportunistic infections, secondary neoplasms, and neurological manifestations. The HIV structure is spherically in shape, containing an electron-dense cone-shaped core which is surrounded by a lipid envelope derived from the host cell membrane. The virus core contains the major capsid protein B24, the nucleocapsid B7 and B9, two copies of viral genome of RNA, and the three viral enzymes protease, reverse transcriptase, and integrase. Now, what is the mode of transmission? Contact with certain body fluids from the infected patients with HIV who has a detectable viral load, and these fluids are blood, semen, rectal fluids, vaginal secretions, and breast milk. Now let's have a look on the pathogenesis of the HIV. The HIV can infect many tissues, but the most important two major targets of HIV infection are the immune system and the CNS. The disease is primarily affecting the cell-mediated immunity, and this is the most important hallmark of HIV or AIDS disease. First infect the T cells, lead to subsequent loss of CD4 T cells as well as the dendritic cells and the macrophages. The infection becomes established in the lymphoid tissues where the virus may remain latent for long periods. Active viral replication is associated with more infection of cells and progression to AIDS. The life cycle of HIV is involving the infection of the cells, integration of the provirus to the host cell genome, activation of the viral replication, and production and release of the infectious virus. As we can see in this picture, starting with the binding of the virus to the human cell membrane through the binding proteins GP41 and the GP120. After this binding, there will be conformational change. This conformational change is going to result also in binding of the chemokine receptor CCR5. Then the GP41 protein is going to help in the penetration of the cell membrane, and at the end this is going to result in membrane fusion and entry of the virus genome into the human cell. Now the enzyme reverse transcriptase is going to act on this RNA to change it into proviral DNA. This double-stranded DNA now is going to be integrated into the human DNA with the enzyme integrase. Then this is going to be part of human DNA, and this DNA now is going to start the replication process through the replicase of the virus, and the human replicase also act on this. The result will be formation of newly synthesized HIV proteins, which is going to be assembled to form a new virion. And this new virion is going to take from the cell membrane a new envelope when going out and released into the circulation as a new HIV virion. Now let's have a look on the acute infection or retroviral syndrome. Now we are talking about the clinical manifestations. 40 to 90% of the patients experiencing acute non-specific illness, which may include fever, pharyngitis, lymphadenopathy, rash, arthralgia, myalgia, headache, and GIT symptoms, oral ulcers, weight loss, which is continuing for 2 to 6 weeks post-exposure of the virus. This duration of acute infection is going to be lasting in 10 to 15 days. Also, there will be hematologic disturbances like lymphopenia, thrombocytopenia. 10 to 20% of the patients may present with septic meningitis, CNS pulses, or other neurological manifestations. Also, we can detect in the CSF of these patients the HIV RNA, and also we can check for the protein B24 in the CSF, associated with high level of plasma viremia. So the patient at this level is going to have a high viral load. So we have plasma viremia in the acute infection retroviral syndrome. So these patients are at high risk of transmission, so they can transmit the infection highly during the acute retroviral syndrome phase. The second stage is the asymptomatic latent stage. During this stage, the HIV infects and replicates in the CD4 and T lymphocytes, so the virus now is targeting the lymph nodes. The normal CD4 count in adults is around 500 to 1,100. The CD4 count is going to drop to 60 to 100, from 60 to 100 cells per year, but it is variable among patients. By 10 years post-infection, 50% of the patients have advanced HIV. So during these 10 years, the patients are going to turn into the next stage, which is AIDS. 30% is going to demonstrate milder symptoms, and less than 20% are going to be asymptomatic if untreated. Now we are in the third stage, which is the AIDS stage. Here the HIV positive and one or more of the clinical illness are characterizing AIDS. This including opportunistic infections like pneumocystic jirovecii pneumonia or pneumocystis carni, previously was named like this. Also esophageal candidiasis and cytomegalovirus, also Mycobacterium avium complex, tuberculosis and toxoplasmosis. Also, there is incidence of malignancies like Kaposi sarcoma, invasive cervical cancer, and wasting syndrome or CD4 less than 200 or less than 50%. This is largely historical because now after the insertion of the ART, antiretroviral therapy, this can help in reversing the CD count decline. Now here in this table we can see the symptomatic stage in which the CD4 count thresholds for the classical clinical presentation. Here, what is the level of CD4 count and what is the possible manifestations? If the CD4 count is less than 500 cells, then the patient is oftenly asymptomatic but can have some constitutional symptoms like fever, night sweats, fatigue, and weight loss. Also mucocutaneous lesions like seborrheic dermatitis, HIV, herpes simplex virus, varicella zoster shingles, or oral hairy leukoplakia and candidiasis like in oral candidiasis and esophageal candidiasis or vaginal candidiasis, and also Kaposi sarcoma. This also can be associated with recurrent bacterial infections, especially pneumonia. Also, pulmonary and extrapulmonary tuberculosis can be expected with less than 500 CD4 count. Also, lymphoma can be encountered. Less than 200 cells is going to be associated with pneumocystic jirovecii pneumonia, which is previously called pneumocystic carni. Also Kaposi sarcoma, oral thrush, local and disseminated fungal infections like the Cryptococcus neoformans, Cryptococcus imitis, and Histoplasma capsulatum. In patients who are having the CD4 count less than 100, then we can expect progressive multifocal leukoencephalopathy, and this is caused by the GC virus. Also, CNS toxoplasmosis is common at this level. If the patient is having the CD count less than 50, then they are at risk of developing cytomegalovirus infection manifested as retinitis, colitis, cholangiopathy, and CNS disease. Also, Mycobacterium avium complex are presented at this stage. Bacillary angiomatosis, which is due to disseminated Bartonella infection, can also occur. Primary CNS lymphoma is common at this level of CD4 count. Now, what are the types of testing available for HIV? There is nominal name-based HIV testing, non-nominal non-identifying HIV testing, and anonymous testing. The nominal or name-based HIV testing here, the person is ordering the test knows the identity of the person being tested for HIV. HIV test is ordered using the name of the person being tested. Here, person ordering the test is legally obligated to notify the public health official if the test result is positive. So, if there is positive result, there is notification to the public health officials. Test result is recorded in the healthcare records of the person being tested. But if there is non-nominal, non-identifying HIV testing, although it is similar to the previous one, but here the HIV ordered using a code without using a name. There is a code of the initials of the person being tested. This is why it is called non-nominal or non-identifying. The third type of testing is anonymous testing, and this is especially available in specialized clinics. Here, the person ordering the HIV test does not know the identity of the person being tested. And here, the HIV test is carried out using a unique non-identifying code that is only the person being tested for HIV knows, so no one can know the result. Here in this case, the test results are not recorded on the healthcare record of the person being tested, and the patient identification and notification of the public health required to gain access to the antiretroviral therapy. So the patient identification and notification of the public health is required for the ART therapy. So in anonymous testing, there will be no accessibility for the public health notification and for the access of the ART or the antiretroviral therapy. Regarding the disclosure of HIV to the sexual partner, there is two conditions that it is not considered a criminal offense not to disclose HIV if there is retroviral therapy ongoing with a viral load less than 200 copies for at least 6 months. Also, if the patient's viral load is between 2 and 1,500 copies per ml and a condom is used properly and does not break. Laboratory diagnosis, we can do anti-HIV antibodies, which is detectable after a median of 3 weeks, all by 3 months. Therefore, their 3-month window period in which the antibodies can be negative, but the patient have the infection. Initial screening test is by using the 3rd-generation antibody testing like ELISA. ELISA is going to detect the serum antibodies of HIV, and the sensitivity of ELISA can reach more than 99.5%. Increasingly, the combination of B24 antigen and the HIV antibody testing by using the 4th generation is used for the screening in order to improve the sensitivity in early and acute infections and the sensitivity specificity approach, which can reach to 100% for chronic infection. Confirmatory tests, if positive screening, we are going for the confirmatory test like the Western blot confirmation by detecting the antibodies to at least 2 different HIV protein bands like the B24 and the GP41 and the GP120 or GP160, and this specificity is exceeding 99.99%, almost 100. Another type of testing is the point-of-care testing, rapid antibody test with higher false positivities. Therefore, it needs to be confirmed to confirm the positive results with traditional serology testing. We cannot depend on the positive results of the point-of-care testing. Also, the P24 antigen detection by using ELISA may be positive during the window period. So the management of HIV positive patients is after verifying the results of HIV to make sure it is positive, then we are going to complete baseline history and doing physical examination and doing follow-up every 3 to 6 months. Also, we need to do laboratory evaluation if non-stable and non-suppressed viral load, or the routine CD4 count to measure the status of the immune system. So we need to assess the status of the immune system. Doing routine HIV RNA levels or the viral load, doing the viral load is very important indicator for the effect of ART. So we are going to monitor the therapy of ART by doing viral load. Baseline HIV resistant testing to guide the ARV virus therapy. We can do baseline viral load in order to understand if there is resistance to the ART load of the ART therapy. HALA B5701 genetic testing is important for screening of the abacavir hypersensitivity if considering abacavir in the treatment regimen. If we are using the abacavir, then we need to check for the hypersensitivity by doing the genetic test of the HALA B5701. The CCR5 tropism testing is considered CCR5 antagonist in the treatment regimen. Another modality is the CCR5 antagonist, and this considered in the treatment regimen if there is CCR5 tropism. The baseline tuberculin testing, there is in duration greater than 5. It is different from the reading of the BB test in normal patients. In normal patients or normal individuals, we need to, in the induration to consider the test positive, we need a 5 millimeter induration. But here in HIV, we need only an induration of 5 millimeter to consider the test positive. Baseline serologies like HIV, like hepatitis A, B, and C, and syphilis, plus toxoplasmosis, cytomegalovirus, and varicella zoster virus are going to be conducted. Routine biochemistry and hematology X-ray and urine analysis also are going to be considered. Annual fasting lipid profile and fasting glucose, because of the side effects of the antiretroviral therapy, is going to be needed for the follow-up of patients. So in the management, we started with the verification of the result, then the history and examination and follow-up. The third was the laboratory evaluation, and now we go for education of patients. So regular follow-up on viral loads during 3 to 6 months, as well as strict adherence to the ART therapy, improving the prognosis of patients. We need to do routine monitoring of the CD4 count until it is consistent to over 500 cells with suppressed viral load. So we need to follow up the patients by the viral load and the CD4 count. Prevention of further transmission through safer sex and clean needles for intravenous drug users. We need to make sure that we prevent further transmission to other patients. HIV superinfection, like transmission of different HIV strains from another HIV patients, can be rarely occurred, so barrier protection during sex is still recommended. We are going to recommend sex protection barriers. Also discuss the importance of disclosing the HIV status to partner, including risk of criminal prosecution of non-disclosure in jurisdictions where applicable. Also, we need to connect to the relevant community groups and resources. Another important point in the management of HIV patients is the healthcare maintenance. We need to make sure that assessment of psychosocial concerns and referral to psychiatry or social work if appropriate. Also, vaccination like influenza annually and the 23-valent pneumococcal vaccine every 5 years. Also, the hepatitis B virus vaccine if it is not immune, in addition to the hepatitis A virus if the patients are seronegative, in addition to human papillomavirus vaccination. Another thing is the annual screening by doing pap smear or regular sexual transmitted infections screening. Also, management of comorbid conditions and provision of general primary care. So we need to check also for comorbid conditions, regular sexual transmitted screening, pap smear, vaccination, and psychosocial concerns. Regarding the pharmacological therapy of HIV, we have different classes of drugs like the nucleoside reverse transcriptase inhibitors, the non-nucleoside reverse transcriptase inhibitors, protease inhibitors, integrase strand transfer inhibitors, and fusion inhibitors, plus the CCR5 antagonist. The most important point in this table are the side effects of these drugs because for example, lactic acidosis is caused or occurs secondary to mitochondrial toxicity, which is a common side effect occurring with the nucleoside reverse transcriptase inhibitors. Here, the symptoms of lactic acidosis will be including abdominal pain, fatigue, nausea, vomiting, and muscle weakness. Another important side effect, which is the lipodystrophy. Here, the body fat distribution, mainly associated with the old antiretroviral therapy, is occurring in two pictures, like occurring in lipohypertrophy as a lipohypertrophy or lipoatrophy. Lipohypertrophy, for example, dorsal fat pad, breast enlargement, increased abdominal girth. It is thought to be caused primarily by the group of drugs of protease inhibitors. Protease inhibitors like the darunavir and the indinavir. Also, lipodystrophy can be presented as lipoatrophy, for example, presenting with facial thinning, decreased adipose tissue in the extremities, and this is commonly associated with treatment by thymidine analog nucleoside reverse transcriptase, such as the zyoviudine and the staviviudine. And the zyoviudine and the staviviudine are also associated with other side effects, like for the zyoviudine, it is associated with bone marrow destruction and or suppression, and also myopathy. For the staviviudine, it is associated also with peripheral neuropathy and pancreatitis. Another side effects are the metabolic abnormalities that, like lipids, affecting lipids, like increasing the LDL and increasing the triglycerides, glucose abnormalities like insulin-resistant type 2 diabetes mellitus, and increased risk of cardiovascular disease. Another important point is the usage of antiretroviral therapy during childbearing age without using effective contraceptive methods. Some drugs are associated with neural tube defects like the integrase strand transferase inhibitors. Mainly, the dolutegravir is very commonly associated with the neural tube defect. In the other side, there is some safe combinations from the nucleoside reverse transcriptase inhibitors like the FTC and the lamivudine and the tenofovir fumarate. These drugs in combinations are safely used during the childbearing age without usage of effective contraception. In addition to the treatment, we need to give prophylaxis against opportunistic infections in HIV-infected patients, like, for example, pneumocystic cardiac. When the CD4 count of the patient is less than 200 cells, then we need to give trimethoprim sulfamethoxazole 1SS or DS once daily. Also, we will give trimethoprim sulfamethoxazole 1DS once daily for the toxoplasma gonadie when the immunoglobulin G antibody is detected for the toxoplasma and the CD4 count is reaching less than 100 cells. Also, regarding the mycobacterium groups tuberculosis, when the skin test is positive for HIV patients, that means more than 5 millimeter, or there is a contact with someone who is having active tuberculosis. In this case, we are going to give INH and we will add pyridoxine daily for 9-month duration. Also, for the Mycobacterium avium complex, when the CD4 count is less than 50, we can give the rifabutin 300 mg, but the prophylaxis treatment is not indicated, or there is no prophylaxis if the patient is already started the antiretroviral therapy.